joined by Chris Jenkins. Chris, welcome to the Zoom call and this programme.
Thank you very much.
Perhaps we start off by, I'll just ask you to tell us a little bit about yourself. What's your role? What is your work?
Thank you very much for having me on this. Firstly, professionally, I work for a company called Ipsos, which is an independent research organisation. I've been doing that for about a year. For the few years before that, I was working in research for other organisations. I was working for non-government organisations, and then I was working for Queen's for about 5 years with the Centre for Public Health, mainly in global health research. I did my PhD at Queen's. Before that, I went to University of Nottingham, and then I was in Geneva doing a master's. And for a couple of years was then working internationally with different global health programs. So Share Uganda as an organisation starts way before me coming back to Queen's to do a PhD. But Share Uganda does start in many ways at Queen's University. So in 2008, there was a number of students who were studying at Queen's at the time. I actually was still in high school at the time. I was 17 whenever these conversations started to happen. That group that came together went out to Uganda and met a man called Dominic McQuire, and really Share Uganda's story came together at that point because a partnership and a relationship was developed with him that then allowed everything that has come over the past 15 years to develop.
My name's Lorna Montgomery. I'm a senior lecturer in social work. I've worked here for about 9 years, and prior to that I worked for about 20 years at various levels in the statutory sector as a social worker. Probably when I just started working as a social worker, I had a couple of trips out to Uganda as a volunteer. I think I worked in a respite home for children with disabilities. So I had an interest in that, and then in 2003, where I'd worked as a mental health social worker here for many years, I took a 5-year career break and went and worked as a social worker, mental health social worker in Uganda for an NGO. I became interested in research, and so I started my PhD in Uganda. And I looked at a comparative study of therapeutic interventions between Uganda and the UK. So I finished that when I came back home to the UK, and I got a job at Queen's then. Obviously I had relationships in Uganda. It was important to me that I sought opportunity to continue those relationships and that work if I could. And so I looked for opportunity to do that, and I met with Chris Jenkins. So he talked to me about the work of Share, and I think then we both, and with other people, thought about how can we build on that.
So tell me about Share Uganda. What sort of an organisation? What are the aims?
Yeah, so we're a community-based health organisation. So as I kind of said, to give a little bit even of the wider context as well, whenever we went to Uganda in 2008, we really didn't have an awful lot of an idea about what we wanted to do. We essentially went out to Uganda to try and meet people and to see if there was any gaps that we could develop programs and support. But we had very little idea about what that might look like. We met this man, Dominic McQuire, and it's really worth saying a little bit about Dominic because it's just one of the most amazing, inspiring people that I've ever had the privilege of meeting. And Dominic lives and works in an area of Uganda called Kibera. It's in the Chotara district. It's in the very south of the country, near the Tanzanian border, near Lake Victoria. And Dominic trained to become a teacher, decided he wanted to go back to Kibera, came back into the community that he grew up in. There was no school provision at the time within the community. So he started with his wife that he met at university, Rose, and set up a school. And they had six kids initially in one room. And that's how they started. And about 15 years later, they have I think it's the fourth best performing school in Uganda this year, academically. Like, just this remarkable story of going from very, very little to just a very high performing school that does amazing things. And it's also an incredibly holistic school. They have wonderful arts and sports programs, but very much in this area of very high deprivation and with very little access to other educational facilities. So we arrived into that and were just blown away by some of that work that was starting 15 years ago. But it was very clear at that time that there was a real gap within healthcare. There was no functioning health services within the area. And we were just seeing a massive, the impact of things like HIV. One of the first recorded cases of HIV in Africa was very close to Tratira, and you can just see the visible impact of it. And frankly, a missing generation of people that were affected by HIV/AIDS. So the impact of malaria is an incredibly dangerous disease, particularly if you're young or you're pregnant or you're elderly, but also a very preventable and easy to treat disease as well. And yet but essentially even taking it without a specific focus on those, on certain conditions and diseases, just a lack of access to any sort of health service, a lack of access to be able to talk to a healthcare professional. So we started to try to identify and develop health projects. And we started really, really small. And I think that is one of the things that I'm really glad, looking back on our approach, that we took this approach. We were young people, 18 to 22, and very will openly say that we did not have a great idea about what we were going to do. But I think we approached it right. We took it really slow. We listened an awful lot. We didn't dive in head first. And we really supported Dominic and other local people in the community to take a lead on all of that, because what does a group of young people in Northern Ireland really know about the experience of living in rural Uganda? So we very much came in with an approach that we can help facilitate this. We can open up funding for some of these projects. We can help steer this. We can create a partnership, but this is to be led by local people. And looking back, I'm really, I think that's one of the things I'm really glad that a group of young people took that approach. And, you know, because it could have been quite different. So then we started developing health projects, started really small. We started with things like malaria prevention programs, which was mosquito net distributions, but aligned that with other things like educational workshops, and also having in place like an infrastructure to support the use of nets. So just really simple things, having needle and thread on hand, people knowing how to repair them. And again, that's all delivered by a community outreach team in Uganda. Things like installing the nets, it's really like, it's such an obvious thing whenever you think about it, but the way that a lot of mosquito net programs work is that a organization will come, they will leave, you know, a couple cardboard boxes of mosquito nets in the village. So we have a team that would go house to house and would kind of help install the nets as well. And it's just a really simple but essential component to making sure that these sort of programs work. So we started with things like that. We did health outreach camps. We started to fund people, young people within the community that were wanting to do medical education. And then this all kind of culminated a few years ago in constructing a primary healthcare centre. And that was finished a few years ago now, and offers primary healthcare services within the Kibera community, staffed entirely by Ugandan medical professionals, led by a clinical officer. And she originally was a nurse within the community. We supported her to go through her qualifications to become a clinical officer, which allows her to manage the clinic. So there's a women's empowerment element to that as well. And just the impact of having a healthcare centre that's accessible, that's in the community, that can treat basic health problems. And really importantly, if someone has something that's more serious can identify that and can refer on to other facilities as well. So that's where we've kind of got to now, and it's not perfect by any means. We're constantly working to try and open it up and make it more accessible, create better links with other healthcare providers in the area who provide things that we can't provide. So if we're referring on, but they're being referred on to a very expensive service, how do we manage and support that? So we're constantly trying to expand what we can do. And I guess on the Northern Ireland side and on the sort of the more international side, we've maintained a model of doing this entirely voluntary. So Share Uganda in the UK and Ireland has no staff, and as a result has essentially no costs in Northern Ireland. Our only costs would be very minor things like website hosting and things like that. So essentially all the money that we raise goes directly out to Uganda as well. So it's a small is beautiful model. I definitely think that there's a space, by the way, for larger NGOs that do have. So I think sometimes there's an argument that that NGOs shouldn't have any staff internationally, and I actually don't agree with that. But for us, this is the model which worked really well, and it has its benefits because we're able to direct as much of the resources as possible to Uganda, and also because it's the smallest, but a sort of small is beautiful model. It's still entirely about relationships and friendships as well, which I think is really lovely too. We've kind of grown up as Dominic and his family have grown up, and I get as many texts from Dominic via WhatsApp about Man United beating Liverpool last week, which I wasn't very happy about and he was very happy about. I get as many texts about football, I get as many texts about how his kids are doing in school as I do about projects. And I actually think that's really lovely as well, because it's that relationship's at the heart of it. And it does mean that whenever we need to have a conversation about something to do with the different projects, it's a conversation that's happening on that foundation of really good trust and a really good relationship that's been developed over a very long period of time.
So in 2018, we worked with Share and developed a relationship with academics in two of the key universities in Uganda, Montgomery and Clark International. And since then we have got funding for 3 projects. And I think more importantly, maybe we've built that team. Like I do feel it's a genuine collaborative international team. We work hard at our kind of cross-cultural engagement, about the role that we have in it, and that we don't lead everything. We ensure there are leaders from Uganda. I know that there's a lot of discussion about the producers of research being disconnected from its users, and so I think we have a really strong emphasis, particularly with Share, in working collaboratively and at the level at which the research is going to be used.
Roughly how many staff are involved in the Ugandan end? Obviously there are none here in Northern Ireland, but how many people are involved?
So it's pretty small, in the healthcare centre. I think it's 6. At the minute it's a clinical officer, a couple nurses, someone that works in a small lab, and then we have an admin person, a security person. So it's 6 people within that, within the healthcare centre. And then we have a malaria prevention programme that has a couple other people that kind of work sort of on a more sort of part-time basis with it. So to help put up the nets and things like that. And we have people like Dominic and Rose who are kind of the managing advisor sort of figures. We have a committee there that kind of oversees everything, again, of kind of more senior retired healthcare professionals, people like that, who kind of oversee the work as well. So there's a couple of different groups of people that are both involved in formal employment and then also in kind of more advisory or part-time roles as well.
So we've got 3 small grants. The first, I think, was about 2019, and it was a GCRF fund. small amount of money where we set up a 3-day workshop and brought together key stakeholders across the health and social care sector and academia and government. And coming out of that, there was a clear need for understanding the experiences and needs of informal carers in Uganda. So strong sense of a very difficult healthcare sector, very limited resources, a lot of poverty, and huge reliance on children, older people, family carers, but with really very limited research done in that area and no resources. So we got a second small grant from GCRF again to look at the needs of carers, and we conducted that research with, again, that collaboration that I've talked about, and we looked at the needs of carers in 2 locations, in the area that Share is based and in the capital city in Kampala, and we worked with the Hospice, Africa Hospice Uganda. We engaged with the Ministry of Health and they invited us to write a draft of a carers policy. So we're in the process of doing that, and then just more recently we've got a small impact fund from Queen's which will help us to develop a carers resource, carers toolkit, and we're working very closely with communities in trying to develop that. I have a trip out to Uganda in October for that purpose, and then we're also continuing to work with the Ministry of Health to develop this policy. So hopefully those 2 will come together.
What is the future? What does the future look like? Do you think it'll continue to grow? What would it need?
I think it can continue to thrive, definitely. And for me, thriving is a couple of things. Firstly, it's ensuring that we're sustainable long term, and I'll talk about that a little bit more in a second. It's also ensuring that we are building a full sort of service around the healthcare centre. So being able to offer as many different services as possible, being able to offer the kind of referral that I was talking about, but also using that space in the health centre to open that up to other organisations as well. So a really exciting thing that is happening quite recently is that we're hoping that we are able to link up with the Ugandan government so the Ugandan government offers their vaccination programs through the health centre, which is fantastic, because I think long term connecting with the public health system is a really important thing that I would like us to do more in terms of sustainability, accountability, all those sort of things. I think it's a really important direction that we connect those up a bit better. But there's other organisations as well. There's the Rakai Health Sciences Programme, which it was funded by the Gates Foundation, and it's now been, I think, brought back in under the Ugandan public health system. They do a lot of HIV testing and treatment, so that's something that we haven't felt that we've been in the position to offer something like that. But we also don't need to, because there's other organisations in the area that have those niche focuses who are doing that work really well. So it's how do we connect with them, bring them in, let them use that space within the health centre, allow the community within our area to access those different services. So I think a lot of what we'll do over the next few years in terms of thriving is that it's building those sort of connections. I don't think our ambition is to actually go beyond in terms of, I think there's a tendency of kind of a growth mindset that you always have to grow. And I don't think that beyond that kind of that those relationships that we're going to try and solidify, I don't think that's what we're going to do. You won't see a hospital in Kibera in 10 years' time. There isn't a plan to build the health centre into something much bigger that's offering specialist tertiary level. That just wouldn't make sense. And also I think would be that would start to stray into the areas of kind of overlap with other services. So it's about solidifying things. And to be honest, COVID has been a really difficult time for everyone as well. So first and foremost, it's just getting back on a level footing after what's been a really difficult few years for everyone. And COVID's been difficult in Uganda for a couple of different reasons. It's been a little challenging to see to assess the direct impact of COVID in Kibera because of a lack of testing. So it's hard to know. If you look at some of kind of WHO statistics and stuff, Uganda doesn't seem to have been affected directly by COVID too badly. I say too badly, I mean that in comparison to other places. And I think that's probably because Uganda took a very strict approach, a very robust approach. Uganda has very robust systems of outbreak control that were already in place, that they were able to basically implement protocols immediately. Uganda's had a long history of dealing with outbreaks such as Ebola, and then obviously HIV as well. So they had those systems in place. So that direct impact has not been that traumatic, but the indirect impact has been massive economically in Uganda. Just a huge impact of shutting the economy down. So really, what we're trying to do is get back on a even footing. And from our perspective in Northern Ireland, we've also seen the impact of COVID very dramatically as well in terms of just the challenges in fundraising. And a lot of our fundraising models pre-COVID were physical, they were in person, there were events, things like that obviously all stopped, and we've had to transition a bit of that as well. So first and foremost, long term for Share Uganda is just ensure our long term sustainability, build up those different relationships, and then work with the community as well to see what they would like to see next as well. I think one thing I didn't mention as well is that one of the things that we will like to do going forward is to shift the kind of income generating stream from Northern Ireland to Uganda as well. So income generating for the use of the clinic. So are we able to develop different projects around the clinic, agricultural projects, things like that are community owned, and the profit of which goes into funding health services? Just so, again, I think that's a better model than it coming entirely internationally. So can we start to develop more of that? That would be kind of the direction that we're also looking to go.
Our research questions didn't ask specifically about Share Uganda, but I suppose spontaneously a number of family carers. So these are individuals, possibly young people, women, older people, like people who were really very stressed and I suppose didn't cope terribly well with the huge responsibility they had for looking after a member of their family who had chronic illness. And many of them indicated that the projects that Share Uganda ran were the things that kept them going. So provided support, provided practical help, emotional support, guidance, and I suppose that kind of social, psychological support as well. It's always trying to be careful about our own position coming from the West and where power lies, and constantly, almost in every conversation, being aware of that and negotiating respectfully and ensuring that my colleagues in Uganda, who are experts in their own area, take the lead. Resources are very limited. It takes you a while to get your head around an entirely different mindset, different expectations, really no resources. And I'm sure that's made currently worse by just the position globally. The goal of this visit is to develop a prototype toolkit for Ugandan carers. I suppose maybe if I use one example, I have to bear in mind even things like people will not have the money to print material off, or if I want to have an online meeting, people genuinely may not have the airtime on their phone to be able to log on to a meeting, so it's actually starting at the basics and trying to build up from that. I suppose the other thing to say is that I don't want to present it as, a one-sided, we're providing help. I mean, very much we're learning from our Ugandan colleagues, and my views have changed and my skills have developed as a result of that.
I think the thing that would be really helpful for us as an organisation if you're listening to this podcast, it doesn't matter who you are. If you're a student at Queen's, if you're alumni, if you're wanting to get involved in something, please just reach out to us. First and foremost, we need to develop our network in Northern Ireland a bit, where we're looking always to bring in people with different areas of expertise and with just enthusiasm and passion to do this sort of work. So I've given an overview of some of the different areas that we're working in: health, trying to look at income generating things, agriculture, things like that. If you have a background in governance and any sort of project management skills, just get in touch. Would love to hear from you. And it's a hard time for the organisation as well. And I kind of sometimes, I think with charities and non-government organisations, there's a hesitancy at times to talk about funding and fundraising. And I think that's particularly strong at the minute because there's a cost of living crisis in Northern Ireland. There's a lot of people are finding things very, very difficult. And it's sometimes a very difficult sell to say to people, well, we'd like you to donate to a project that's an international project. I think we still need to say that to people, and we need to say that this project is based on an idea of internationalism and global solidarity, and the challenges that are being faced by people in Uganda are very dramatic. And if you have the ability to donate to this project, I would really ask you to consider it as well, because ultimately nothing happens without fundraising. And if you have a little bit of extra money and want to make a donation to that, the distance that will go in Uganda is dramatic. It would have a really unbelievable impact. I think as well, people sometimes have a tendency to want to kind of fund a big or a new thing. And I kind of understand that as well. It kind of comes from, you want to see what your money's directly going into. The majority of our costs in Uganda, the vast majority of our costs are salaries for healthcare professionals and medication. And I would argue that there's nothing better that your money could go into as well. It's funding that direct health service. There's no health service without doctors and without clinical officers and nurses. So you're funding those people to do this really important work. And then that money is within the community and circulating anyway. So it has a wider impact as well. So, it's difficult to talk about fundraising at the minute, but it is also a reality. If anyone does have that capacity to do that, it would be incredibly appreciated. And beyond that, if you're interested, if you have any ideas, just reach out. As I say, our model is entirely a kind of a partnership-based, relationship-based, friendship-based model. I think we're an easy group to come into. So just drop us a message and I'd be happy to have a chat informally as well about anything that we could do together.
And of course, they can always contact you to talk about Liverpool as well.
We'll see how Saturday goes. Normally, for the last 5 years, I'd be very happy to have that conversation, but we'll see how Saturday goes.
Oh, I'm hopeful. I'm hopeful for the future of this project. I am, grateful to be in a position in Queen's where we can use that. My personal interest in Uganda aligns with Queen's kind of global strategies, which is brilliant. And so I hope that it's a bit of a win-win.
It sounds like a really excellent and productive model, and I hope that people will be getting in touch, whether about football or not. We'll obviously put the links on the website, and or people can always contact at QUB Engagement, and we can put them in your direction. But in the meantime, Dr. Chris Jenkins, thank you very much.
Thanks very much, Morris. Really appreciate it.